Yes, it was just great collecting all this time. And naturally, yeah, was quite
Sir, we are live now. Good to go.
such a
Okay. Good evening, everyone, and we welcome you this evening to a very interesting panel discussion on quetiapine, where we're going to speak about quetiapine, different facets of it, and the coming of age of a drug like quetiapine. It's my proud privilege that we have with us present Professor Dr. P.K. Dalal, who is our current president of the Indian Psychiatric Society and professor and head of the Department of Psychiatry, KGMU, Lucknow. Sir, we would like to have your opening comments on quetiapine before we start the first panel discussion.
Thank you, Avinash, and my dear friends. It is good that we are having now webinars and on different molecules, one after the another, and to know about the latest and discuss some of the maybe some novel indications which is coming up for different molecules. Now, as far as quetiapine is concerned, it is a molecule which is, which FDA says there are a number of indications for that. One is about schizophrenia, one is about bipolar disorder, then bipolar depression, then recurrent depressive disorder, then even in dementias, behavioral problems, and then Parkinsonism with what you call psychotic symptoms or other maybe movement disorders. Along with that, if somebody is having some psychotic disorders, so things like it is a very broad spectrum molecule, I would say, and it has got certain sedative effects as well. The only hindrance is its cost, I believe, because of which we are in a government setup. We hardly use this molecule up to 800 milligrams per day, but generally, say in lower dosage, it has been frequently used in bipolar depression or even in recurrent depressive disorder, of course, as an adjuvant, and maybe to some extent in schizophrenia as well, like say up to 400 or 600 milligrams per day. And even if a person is on mood stabilizer, especially a female on mood stabilizer and going pregnancy way or planning for pregnancy, then generally it is being the mood stabilizers at times are being shifted to quetiapine, which is said to be pregnancy factor C. So it is better as compared to pregnancy factor D mood stabilizers. So with all these, and we all know that as compared to clozapine and olanzapine, it is having lesser side effects. Of course, not as less as aripiprazole, or but it is the midway in between as far as the metabolic syndromes, all the contents are concerned. So I think it will be a good webinar and there will be good take-home messages at the people who are using this molecule, and it's quite an old molecule, and we all are well versed with this molecule, and people must have used it. So for a roundtable one, it is a very good conversation, I hope, and with great take-home messages. So with that, I wish you all good for this wonderful webinar. Thank
Yes.
you.
Thank you very much, sir. And so you will be with us for the second panel, which is happening after this finishes. So please be with us and keep blessing us. We now move to our first panel, which is going to look at the role of quetiapine in specific indications. And it's my proud privilege, of course, to start with Dr. Suresh Kumar from Chennai. And my first question to you, sir, is what do you think is the role of quetiapine in bipolar disorders?
Thank you very much. I'm delighted to be among the side panel. Thank you very much, Avinash. First of all, bipolar disorder is often complicated by mixed episodes rapid cycling, subsyndromal symptoms, and often refractory treatment refractory condition. So despite its morbidity and mortality, effective treatments are elusive. Even the conventional mood stabilizers we traditionally employ are really not effective in controlling all the manifestations of bipolar disorder. So I think quetiapine, a versatile antipsychotic, is quite efficacious because it's useful in all phases of bipolar disorder. And then if you look at it, it is both useful as a monotherapy as well as an adjunct to conventional mood stabilizers. So first, if you really talk about, like mania and the mixed states and talk about the treatment of acute phase, you realize this is effective against a broader range of symptoms presented by individuals with bipolar disorder during acute mania and mixed episode. We employ something between 400 to 800 milligram of quetiapine. You can see the improvement from day 5 onwards. Often it is not very difficult to see the change from day 5 onwards if you give a dose something like between 400 to 600. In my clinical experience, around 600 milligram is what is useful for majority of the people in controlling acute mania. You also would be very happy to know that in CANMET as well as International Society of Bipolar Disorder guidelines, this is a level 1 evidence given for acute mania mixed episode treatment. So if you really move to other part of the, like bipolar disorder, which is the depressive part of it, in bipolar depression, you all know it's very extremely difficult to manage bipolar depression because often when we combine antidepressants with mood stabilizers, there is a problem of switch to mania. That's what clinicians are always worried about. Here, we know quetiapine is extremely useful in treating acute bipolar depression, both in adults, males and females. But only the question is whether it is really useful in children and adolescents because the evidence is lacking, but we still empirically provide it in our clinical setting. So the advantage with quetiapine is preventing the switch to mania. So if you look at it, the adverse effects we have, I think Dr. Dalal has very nicely pointed out some of the things like sedation, somnolence, and dizziness, and fatigue, and constipation, dry mouth. But I think the metabolic side effects are also true. That could happen. You should be really, watchful about it. So I think with regard to quetiapine in bipolar 2 depression, this enjoys the level 1 evidence in CANMET and International Society guidelines. But I think at the moment, quetiapine is probably the best drug to employ if you make a diagnosis of bipolar 2 depression. And I think this is also not only useful in acute treatment, it's also useful in a maintenance treatment. So I will stop here and allow other panelists to talk about their comments. Thank you, Avinash.
Right. Thank you. Well, moving to Dr. Amrit, what is according to you, the role of quetiapine in major depressive disorder?
If you look at quetiapine, like Sir was talking about, we'll classify depression into 4 subtypes based. One is it works very well in post-schizophrenic depression. Like if you have somebody with psychosis who also has secondary depression or a post-psychotic depression or a post-schizophrenic depression, I think quetiapine is a wonderful drug. Dosages, like we are very apologetic when we use dosages, 25 milligram, 50 milligram, and then we reject a drug. Like Sir was talking about 300 milligram, 400 milligram. Initial part, which is not very dose dependent, is the somnolence and a little bit of, the expenses what Dr. Dalal was speaking about. But then if you can give a very good quality of life to somebody and we need not give 4 drugs, 1 antipsychotic, 1 sedative, 1 antidepressant, 1 anxiolytic, I think quetiapine fills up all the 4 things in terms of being antipsychotic, being antidepressant, being anxiolytic, as well as a good sedative. So we can, if you mix 4 drugs, it will be less than the price, of what we are thinking about in terms of cost. The second aspect Sir was speaking about is about bipolar depression. Like bipolar depression is the most difficult job for a clinician. If you look at all the, even if you look at borderline, people talk about borderline, but I would, in my clinical experience, I would find that bipolar depression is the worst disease that somebody can have. They would always want mania. They would always want to be in a state of hypomania. So the treatment compliance part is a very, very difficult part. And here, I sometimes feel if you look at lithium, if you look at quetiapine, you can always look at quetiapine also as an alternative in terms of lithium augmentation or quetiapine augmentation. If you look at olanzapine fluoxetine combination, some studies are telling this good. Some studies are telling that is not, placebo-controlled trials have not yielded good results. So you can always also think of quetiapine as an alternative to a fluoxetine, olanzapine combination or augmentation with lithium. Next is severe depression with psychosis. This is one segment of population. Again, we look at it, either they are the very severely depressed people, or they are the geriatric people, or they might be the bipolar people. Many times when we see people with bipolar depression, we have to think of a bipolarity. One of the things that strikes to our mind, because many times history is missed, the brief periods of hypomania is missed. So here we can look at quetiapine as a very good drug when you look at depression with psychotic symptoms. Per se, if you come to depression, now maybe I think our choice of molecule sometimes makes many of the treatment resistant. But then genuinely, if you look at depression, it is not that 50% are treatment resistant or we need another molecule. It is not that only 1/3 or 2/3 respond and the rest 1/3 does not respond. Maybe 10 to 15% of the people might need another antidepressant, might not respond to two different classes of antidepressants. And here is where we can think of quetiapine as an augmenting agent. Again, let us not be apologetic about giving 12.5 milligram or 25 milligram. Let us look at a drug, give adequate dose and for adequate time before we discard a drug. Because once you discard a drug, the next clinician, he loses one armament, which he might be having. So somewhere 300 to 400 milligram, minimum 150 to 200 milligram, maybe slow rise in severe depression, in moderate depression as an augmenting agent. I think it works very well. It improves the appetite, it increases the sleep, it takes care of the anxiety symptoms. Many times depression is comorbid with anxiety, and here quetiapine might have a calming effect. Many times we feel patients are agitated. With antipsychotic, you need to add an antipsychotic. We might have akathisia, we might have a lot of restlessness, and here quetiapine might put have a breaking effect, a calming effect.
Right. Thank you. Well, I move now to Dr. K.C. Chowda, and sir, please give us your idea on the specific role of quetiapine in child and adolescent psychiatric disorders.
Okay, so if you're looking at child, initially it used to be thought that it didn't have too much of a role. But today we know that it does play an extremely important role, even in child psychiatry. In my own private practice, I haven't seen too many cases of schizophrenia in children, but it is not that it is not there, it is not seen. Maybe we are a little nervous about diagnosing it in children because it's not a nice diagnosis to be made in a child. Of course, we see an enormous amount of schizophrenia starting in adolescence, but if you're looking at below the age of 12, it is still something that we talk about with reticence. So, quetiapine is allowed by the FDA to be given for child and for adolescents in terms of schizophrenia. The previous speakers have already spoken about bipolar. So when you have a manic episode in a child, this is one of them, or in an adult, in adolescence, this is one of the most effective medicines that can be given. What we sometimes forget is conduct disorders. And in conduct disorders and in the newly minted disruptive developmental disorder, where you have episodes where the child or the adolescent loses control in a sense and comes out with these episodic disruptive elements. A lot of people talk about using quetiapine for the same. It seems to be extremely effective. Sometimes you just have a kid who you may not actually be able to diagnose into any one specific kind of disorder, but he's just extremely aggressive. He may not fall into the category of conduct disorder or oppositional defiant disorder or whatever. In such situations where, where it is maybe in a term, aggression not otherwise diagnosed, quetiapine seems to play a very effective role. We already have spoken about bipolar disorder in adults. Bipolar disorder in kids, again, not very commonly diagnosed, but quetiapine is certainly one of the drugs that can be used in that.
Right.
Pervasive developmental disorder. Once again, not necessarily the drug of choice, because a lot of people believe that aripiprazole and risperidone are a little more effective. But quetiapine has been used, especially if there is insomnia and aggression. It's also used in tic disorders. Once again, not necessarily the first drug that is given, but it can be used. There's a lot of evidence based towards using quetiapine in tic disorders in adolescents, especially if there is agitation and associated verbal tics. It seems to play a fairly important role. It is used as an adjunct to lithium. It is used as an adjunct to divalproate for bipolar. So if you find that lithium by itself or divalproex by itself doesn't seem to be working too much, and you don't want to keep going up and higher on the doses because you're a little scared of the side effects that start, keep the lithium or the divalproex on the maximum amount of dose that the person can tolerate. And then you can actually add quetiapine to it, and it seems to play an extremely important role. Right. And finally, we talk about delirium in children in the ICU. Even though we don't see too many kids in the ICU, and we hopefully will never see kids in the ICU, but if you do have episodes where the child is in a delirious state for whatever reason, once again, maybe not the first drug that is used, but it is certainly used profusely, taking into account some of the side effects that can be seen. But it is, again, an extremely important drug in our arsenal, and it is very, very effective in such situations. Avinash.
Right. Well, just to inform all our panelists that when we started off the seminar, we started off at 56 speakers. We have zoomed up to 96, 56 viewers. We moved up to 96. So we are moving up. So we have 96 people seeing us. I move now to Dr. Ravi Soni. And sir, please give us your perspective on the role of quetiapine in geriatric psychiatry. And where do you think it's useful?
So, as all the speakers have talked about quetiapine and so many indications it has, in elderly, usually, as I see it, and according to my private practice and my 90% practice is of geriatric patients. So, I see use of quetiapine in psychosis and aggression in elderly. So, if you consider psychosis, so it contains delirium psychosis, dementia psychosis, Lewy body psychosis, plus the psychosis of in a patient of Parkinsonism, where it is because of the dopamine agonist. So, and we usually use in aggression with in BPSD of the dementia patient. So, quetiapine has so many roles in elderly. In dementia psychosis, if we see, usually we start on a lower doses, but gradually we build up. And use of quetiapine elderly always requires precaution, because elderlies are having so many comorbidities. They are having some of the male elderlies are having problems with prostatic hyperplasia. Elderlies are already having problems of GI motility, constipation. Some of them are having glaucoma. So there are so many things happening in their body. We need to take care while using quetiapine. Some of them are having arrhythmias, so we need to take care about QTC prolongation. Majority of the elderlies are on antihypertensive medication, so we need to see that the postural hypotension may cause any adverse event, may cause falls, excessive sedation in the night time may cause falls in elderly. So quetiapine has excellent role in elderly, but we need to start low and go slow. Initial doses should be always 12.5 to 25 milligram, and gradually we can build. So in dementia, BPSD, particularly quetiapine is used for psychosis as well as for aggression. And usually doses is starting doses usually 25, but we need to go up to 200 to 300 milligram for actual benefit of quetiapine. There is study comparing placebo with 100 milligram of quetiapine and 200 milligram of quetiapine for BPSD, aggression and psychosis in dementia patient, and it has shown that 200 milligram is much more better in terms of control of the symptoms and improving the quality of life of the patient as well as the caregivers.
Right.
If we consider delirium, so in delirium, use of quetiapine is always tricky, but very beneficial. It has calming effect on the patient. It induces sleep. And if we go for in higher doses like 50, 100, 150 milligram, it usually controls all the symptoms of delirium. But I usually prefer quetiapine for calming effect and sleep, and together with it, I usually prescribe low dose of haloperidol so that the later on one of the drug can be removed. Apart from that, drug-induced psychosis, particularly in Parkinson's patient where there is dopamine agonists are going on, use of the quetiapine and clozapine, those two drugs are only indicated. So quetiapine is preferred drug, and usually I prefer the dose of 200 to 400 milligram for improvement in the psychotic symptoms, while reducing the dopamine agonist in consultation liaison or in reference with neurophysicians also.
Right.
And DLB psychosis and dopamine agonist-induced psychosis are the two areas where quetiapine has excellent role,
Right.
but it can worsen memory or it may cause confusion that we need to take into our consideration. Thank you, sir. Avinash.
Yeah. Well, we have Dr. Gautam Saha with us. I think sir is going to just be on a flight, so he may not be there for the panel. Sir, would you like to give us any comments on quetiapine, your clinical experience? Dr. Saha? Okay, I think I'm not able to hear, sir. I will now move to Dr. Deepak Raheja, and so welcome all the way from Delhi. Whenever I see you, I'm always a little jealous of all the hair you have, because I feel inferior. So the thing is, anyway, my question for you is: do you think we have reduced quetiapine to a sedative rather than an antipsychotic?
I was, before this talk, I was trying to juggle through to see how best I'm going to try and put my view forward, because as much as one wants to do clinically what is useful for the patient, but one wants to also look politically correct when one wants to make a prescription. And I don't think I could have worded it better than what Dr. Amrit did in terms of, not feeling apologetic or, unassuming for using a low dose. I mean, it is definitely found its place as a sedative, not just in clinical practice in India, but all over the world. And that's because of some specific action. And we perhaps not really looking at using it purely as a sedative for patients with primary insomnia, but we are looking at people who have either a comorbid depression or mixed anxiety depressive syndrome, or who have a borderline personality, or who have some underlying XS1 or XS2, mainly XS2 diathesis. I think quetiapine in low dose as a sedative works much better than trying to use benzodiazepine, because of, at one end you're grappling with an abuse potential, and the other end you're grappling with the possible other side effects of something like quetiapine. But I think it weighs more, according to me, in my clinical experience, it weighs more in favor of using quetiapine because definitely of not really perpetuating abuse diathesis in patients who have underlying predisposition to substance or a pill use. So I think it's definitely a good drug as a sedative, and I don't think we need to feel guilty for using it for the said condition, as Dr. Amrit also so beautifully put it, that rather than trying to use too many drugs, it's a better idea to use one drug that will not just given more sleep, but will also perhaps leads to a better control of either anxiety or depression or mood vacillations and lability, as you would see in these patients.
Right. Thank you, sir. I now move to Dr. P.N. Suresh Kumar. And so my first question for you is, while I did speak to Dr. Raheja about the fact that we use it at a low dose, I mean, what is your opinion of a high dose quetiapine usage in schizophrenia?
Hello, sir. Am I audible?
Yes, sir, you're audible.
Okay. Thank you, Dr. D'Souza, for giving me the chance to talk about high dose quetiapine in schizophrenia. See, we know that there are partial and incomplete responders to various antipsychotics. That is a common scenario in schizophrenia. So, some of the common strategies that we used to employ in the treatment of schizophrenia, when there is an inadequate response or the patient is not responding, then we can increase the dose of antipsychotic, or we can change the present antipsychotic to a different one, maybe more potent antipsychotic, or very commonly we are using antipsychotic polypharmacy. But now, see, we have n number of studies showing that the high dose of quetiapine showing some efficacy in partial responders as well as treatment-resistant schizophrenia. In most of these studies, we can see that the dose, usually the recommended dose of quetiapine in schizophrenia is maximum 600 milligram per day. But in high dose studies, we have seen that they have used up to 2000 milligram of quetiapine per day. So, what are the advantages of when we use quetiapine compared to the conventional antipsychotics or other atypical antipsychotics? Let us say that when we use conventional antipsychotics like haloperidol or any other conventional antipsychotics, we know that the chance of extrapyramidal symptoms are very high. But even with doses up to 2000 milligram of quetiapine per day, the chance for developing the prevalence of extrapyramidal symptoms in most of these studies, it is very less. Then when we come to another problem, that is a common problem with the so-called atypical antipsychotics, especially olanzapine or say even with risperidone, the main compounding factor, complicating factor with the continuation of treatment is weight gain. So here with the quetiapine high dose, the chance of weight gain is slightly above or higher than we can say than placebo. So the chance for increasing or gaining weight is slightly lesser compared to other conventional or the atypical antipsychotics. Then another problem with typical as well as atypical antipsychotics is QTC interval prolongation. You can produce torsades points. But here, even with up to 2000 milligram, ECG changes are very minimal, and QT interval prolongation is also only very slight. So it is not a complicating factor to stop high dose quetiapine treatment in schizophrenia. Then another problem is metabolic syndrome. See, olanzapine is very good, risperidone is very good, clozapine equally very good. But all these medicines, now the main problem, treatment complicating factor is metabolic syndrome. So quetiapine, metabolic syndrome, glucose and lipid dysregulation is comparatively lesser when compared with the head-on-head comparison with olanzapine, risperidone, etc. So we can say that high dose preparation is very well tolerated, and the discontinuation rate, we know that the dose most of the people have used is up to 2000 milligram. Still, the discontinuation rate is slightly above higher than placebo.
Okay.
So, can I say one more point?
Yes, please. Yes.
Yes. So see, olanzapine, we can call it as a multi-acting receptor targeted antipsychotic. The name itself is very fascinating. We can call it as MARTA, multi-acting receptor targeted antipsychotic. So olanzapine's action is not only on dopamine, D2 or D4 receptors. It is acting on serotonergic receptors. It is acting on muscarinic receptors, adrenergic receptors. So we don't know where exactly it is acting. How come if its effect on positive symptoms, negative symptoms, as well as cognitive symptoms. So it's a good, wonderful molecule. High dose is very tolerable, and discontinuation rate is very less. And another good thing is that rapid titration of the dose is possible. Up to from day 1 to day 4, we can increase the dose up to 600 milligram per day. Still, patients are tolerating. And one more thing, that in acute schizophrenia and other conditions, the one of the main problem when we are rapidly titrating or increasing the dose of quetiapine is sedation. We can call it as somnolence. In fact, many of these schizophrenic patients and other disorder patients, they will have agitation, hostility, irritability. So this hypersomnolence, even though it is a side effect, we can utilize this for the clinical effect.
Right, sir. Right. So we'll come back to you. Thank you very much. I now move back to Dr. Suresh Kumar from Chennai, from Dr. P.N. Suresh Kumar to Dr. Suresh Kumar. Well, so what mood stabilizers would you sort of like to combine with quetiapine in bipolar disorder? And what about a lithium quetiapine combination? What do you think are the pros and cons? So you're muted, sir. You'll have to unmute yourself.
Thank you, Avinash. First of all, like when I was a young resident and then became a young psychiatrist in the early 80s, I used to see prescriptions which were not monotherapy, would always make me feel that is all unscientific prescriptions, and I used to be very critical about it. It took a time for me to realize cocktails are the regular way to do when we deal with bipolar disorders. It's not as though that, we talked about quetiapine monotherapy and we said it's very advantageous. It enjoys a level 1 evidence in many guidelines. But in real world practice, we often have to resort to adding a mood stabilizer, or you have actually started off with a mood stabilizer. You need to add quetiapine. But if you really want to combine, my choice always would be to choose lithium first, because, maybe my age or, whatever it is, I always been favoring lithium as a gold standard medication. And then I'll then only lean on to, valproate. So when you talk about these drugs, where do I actually combine? In case I started off with quetiapine as a monotherapy, I actually look at quetiapine as an add-on to when I started somebody on lithium, I look at quetiapine as an add-on when there are some symptoms. Those symptoms are very advantageous when you combine with quetiapine. All the speakers have alluded about insomnia. This is one drug which is capable of addressing insomnia than any other drug. And also the psychomotor agitation. Psychomotor agitation, aggression, irritability gets very easily controlled with quetiapine than any other medication. That's why it's extremely popular with clinicians. And also when you have a problem, either the depressed mood or in the elevated mood, when lithium is not really controlling that mood, and I think it's a great drug. Lithium does wonders with elevated mood, but not so much with depressed mood. So obviously, like quetiapine is a good choice when the mood is really worrying us. And I think sometimes racing of thoughts, pressure of speech, is also kind of things that we improve very well with quetiapine. Hypersexuality is another important symptom. I often find that more than mood stabilizers, quetiapine is a good target. Finally, I think somebody presents with mania with psychosis or depression with psychosis. These psychotic symptoms don't necessarily respond very well with antipsychotics. With mood stabilizers, you need to add quetiapine. So that's very important. But I think we really look at clinically the difference between adding sodium valproate or lithium in combination with quetiapine. All of them are doing magic with regard to prevention of mania or depression, very good agents in treatment of maintenance condition. But having said that, I also use lamotrigine in addition to, when you're dealing with bipolar depression, some of the refractory bipolar depressives, in addition to quetiapine, I also employ lamotrigine. That's also a very, very favorite drug. If you start very slow and goes, low and slow with this medication, it's an excellent drug. Combination of lamotrigine and quetiapine is extremely helpful for a number of people with refractory bipolar depression, particularly bipolar 2 kind. So particularly asked about lithium and then quetiapine, which is actually my favorite. What would you actually look at as the advantage? I actually talked about many of the advantages that one would see with the lithium quetiapine combination. But I think the combination is extremely useful, particularly when you're dealing with acute mania or acute depression and maintenance. Clearly, combination scores over monotherapy as a standard treatment for many of us who are dealing with bipolar disorder on a regular basis. So, but then one has to be very careful when it comes to side effects. There are some overlapping side effects. There are some side effects which can get augmented. And I think that's what is really important. So if you give both lithium and quetiapine, in clinical practice, you see a number of people very sedated, extremely dizzy, and then, somnolent, and also complain of dry mouth a lot. That is something that you often see with the combination. Finally, I think you also have this problem. I think one of the speakers, I don't know his real, because I can't see his talking side. He was talking about, sometimes in the older people, when they have, irregularity of the heart, when they have arrhythmias, and these are a bad combination, lithium and quetiapine, is probably not the best thing to combine, but particularly older people presenting with heart difficulties. So that could sometimes be a life-threatening situation, but it's rare. But I think one should be really warned of that. So also I believe the combination also improves, increases the tremors a lot. A lot of people, lithium-induced tremor gets aggravated with quetiapine. So these are the things one should really combine. But I think the combination is wonderful for mixed states, for rapid cyclates, for people who don't get, treated with a single medication. This combination is the combination I'll lean upon quite quickly.
Right, sir. Thank you. I now move back to Amrit. Well, Amrit, what antidepressants do you generally like to say combine with quetiapine? Quetiapine more as an augmenting agent. And are there any specific symptoms of depression that you think you target with quetiapine?
Like sir has spoken about bipolar depression, use of quetiapine in augmenting agent. So also if you look at unipolar depression, be it psychotic depression, be it major depression, which is treatment refractory. Generally, these are the two points we think about when we think of adding quetiapine. So the commonest molecule which acts very well with quetiapine, I think, is a sertraline, because sertraline as an very good when you use it for psychotic depression. So and then if you add quetiapine to it, it is very good. Then we have paroxetine, again important. And wherever anxiety is so important, or might be a very, very important part of the symptomatology for the patient, you use paroxetine combination with quetiapine, or a venlafaxine or a desvenlafaxine in combination with a quetiapine works very, very well. Now look, if you look at a combination with metazapine, which is a NASA, again both the combinations might have little issues in terms of the somnolence part, in terms of the weight gain part again. So when we are, because we have to understand what are the things we should understand when we add something as an augmenting agent. So generally with metazapine, I don't add. If I look at SSRIs, it is generally a sertraline or a escitalopram or a paroxetine. Again with fluvoxamine, there is a problem with sedation and weight gain. So metazapine and fluvoxetine along with quetiapine sometimes synergistically do more harm than they aim at. So SSRIs, SNRIs, TCAs occasionally, if the anxiety part, if the agitation part is very, very significant, that's how I look at it.
Right. Thank you. I now move to Dr. Chowda again. Sir, what do you think is, what would you comment on the dosage of quetiapine in children? What would be the starting dose and what do you think would be the maximum dose? And I'm also adding an audience question which has come in, that do you think there's a role of 12.5 mg and lower doses in children?
Okay, I don't know about lower doses, but 12.5 certainly. So the younger the child, the lower should be the dose, frankly. I think we all have to realize that if you're an adult and you have side effects, you might just choose to refuse to take the tablet. If you, on the other hand, are a young kid, perforce you are made to take the tablet very often by your parent. And you may not be able to verbalize what is happening to you as effectively, and that might itself cause an issue. So my thing with working with kids is give as little as you can, as low dose as you can, and work your way up very slowly. So 12.5 is certainly something that for your younger child should be the starting point. And maybe every 10, 15 days, work your way up by another 12.5, seeing the side effects that occur. For an adolescent, you can of course start off at 25. There should not be a problem. So in answer to what the audience person said, yes, 12.5 certainly is would have an important role to play. I'm a little skeptical about less than 12.5. Others you'll end up with 5 and 6 and 7 milligrams, which I don't really think makes sense. If you're giving it, you're probably not going to start off by using it right in the beginning. You're going to have tried other medication, and 12.5 should be a good enough dose. What is the maximum? For most kids and for most adolescents, about 100 to 200 milligrams actually should be enough. But we do have some very obese adolescents, and we do have some very obese children as well in today's generation, which would maybe have not been there about 15 or 20 years ago, but I'm having a lot of youngsters coming in who are very big in terms of their build. In such situations, we do go up higher. The maximum dose that has been used in a 17 or 18-year-old adolescent has been as much as 500 to 600 milligrams. Some people have gone up to 800. I never have. but apparently you can go up to it, and there is evidence to show that you can go up to it in very, very rare restricted cases.
Right.
200 to 300 seems to be the maximum that most people would need to use in children and adolescents.
Sure. So while we are with you, we'd also like to know any particular side effects you've seen with the use of quetiapine in children with the autism spectrum group. Because there's always a worry about using any kind of drug
Any
in this
kind of
group.
thing.
Yes. Yeah.
Frankly, no. I have not really seen anything. But for the autism spectrum group, especially since very often communication is a problem and they cannot really, convey what they feel inside, and maybe if they're screaming away to glory and you keep upping the dose of quetiapine, that becomes a bigger issue. Almost invariably, we would ask the parents to do a cardiogram on them so that you're kind of checking out on QTC intervals, especially if you're going up on the dose. We must realize that the child in the autism spectrum disorder is very unlikely to be able to convey that he's feeling funny or that his chest is having an issue, or, that he's feeling a thuk happening, which the person who doesn't have ASD does. So we are a little more careful, and that is one thing that I would always do, that is the QTC.
Right. Fine. Thank you, sir. I now move to Dr. Ravi Soni again. Dr. Prasad Rao, sir, please stay with us. I'm coming to you in 2 minutes. I move to Dr. Ravi Soni. What do you think is the role of quetiapine in behavioral and psychological symptoms in dementia? Is there any specific role? And also, since you did mention Lewy body dementia, there's a question from the audience that generally we are afraid of prescribing antipsychotics in any case of Lewy body dementia. So from your geriatric psychiatry experience, would you use quetiapine in a case of Lewy body? Yeah.
So, sir, as I have previously told that quetiapine has a role in psychosis and aggression in elderly. So in dementia also, if we consider that behavioral and psychological symptoms of dementia, so in scale, if we consider assessing it on a scale, so neuropsychiatric inventory has 12 domains of all the symptoms, and there are 2 domains of vegetative symptoms like eating and appetite disorder, and another is sleep and nighttime behavior disorder. Other functional psychological domains, if we consider the psychosis and aggression and somewhat agitation domain, quetiapine has role. So these 4 domains in BPSD, particularly psychosis, aggression, agitation, and sleep and nighttime behavioral disorders, quetiapine has role. Psychosis, but there is always question that how much dose should you use. It is always indicated that if you want to improve psychosis or aggression in dementia, you need to go little bit higher than usual dose. So it is always more than 150 or 200 milligram in dementia patient with BPSD. For sleep, only for sedation, if you are using quetiapine, then 25 to 50 milligram would be enough. If you want that patient should be calm throughout the day, you can go for sustained release preparation, which can be given even during daytime or during evening hours, so that patient can have calming effect throughout the day, which also improves psychosis, aggression, and agitation. So this is about BPSD in dementia. There is also a significant role in a frontotemporal behavior dementia, which when their patient is having behavioral variant of FTD. So in that patient, to control aggression, quetiapine has role, but you need to go higher gradually up to 200 to 300 milligram. And now I'm coming to Lewy body dementia. Yes. I have previously mentioned that quetiapine has role in LBD psychosis plus Parkinsonian psychosis when it is because of dopamine agonist. Lewy body dementia also has some psychological Parkinsonian symptoms. Plus, patient has REM sleep behavior disorder. There is a significant sleep disorder also. So, and obviously visual hallucination. So in that patient, if we the physical profile of the patient allows us to use quetiapine, if the family members are willing to risk that if this molecule can cause sedation and it may cause fall, but they are ready to take care during night hours, we can try, because always we need to improve the quality of life of patient as well as the caregivers. And if the dementia patient is of having moderate to severe dementia, we need to think more about caregivers. Though we are treating the patient, but we are also treating the caregivers. So if a patient of LBD psychosis or Lewy body dementia is having significant visual hallucination and it is bothersome, and patient is also having a sleep disorder, not sleeping at all, and if the physical profile allows us, so we can start with lowest minimum dose 12.5 milligram at the night and gradually increase. And if we don't want that much somnolence, we can always go for sustained release preparation, 100 milligram up to 200 milligram sustained release preparation we can always use. So quetiapine has role in Lewy body dementia also, sir.
Right. Thank you. I now move back to Dr. Deepak Raheja, and sir, I have two questions for you. One is, so we are not able to see your video. So I don't. Yes, yeah. Anyway, my two questions to you is, one is that, and this is one is a question which I want to pose to you, that what is your experience in prescribing quetiapine more than 100 mg? That is one. And secondly, there's an audience question for you, that why is it that psychiatrists are scared to up titrate the dose of quetiapine above 200, 300 mg?
So I think it is a very relevant question, that because we've also partly gotten used to using quetiapine in low doses, sometimes to up titrate begins to give us a little bit of anxiety. I think quetiapine in high doses also has a huge role to play. And sometimes I think we deprive ourselves and our patients from getting the right benefits from up titrating the dose to an optimum level. So essentially, for conditions where one is looking to treat borderline personality disorders, one is trying to look for patients with mania and trying to use it with primarily mood stabilizing properties. I think not just beyond 100, it's beyond 200 and beyond 300 and beyond 400. And when it gets to the spectrum of being used for schizophrenic symptoms, hallucinations, and delusions, So I think also the increased prefrontal cortex activity is seen on high dosages, which is concurrent to the improvement in negative symptoms. So I think it is very important for us to understand that as a spectrum, it is a wonderful drug, and we should not belittle or cocoon ourselves from using it in low doses, because then we are really depriving our patients from getting the right benefit. So, for a drug which almost sounds like a utopian drug, which is the hallmark of a combination of being anti-manic and a mood stabilizing and antidepressant, and so and it in clinical practice does convert. Especially also, like somebody said, Dr. Suresh said, in bipolar depression, it's a wonderful drug. In mixed episodes, a lot of time when you need time to buy time, I remember when I was doing my residency, my guide used to encourage us to make a diagnosis of, in the initial 2 mental status examination, of NYD, which is not yet diagnosed, and so in the initial period, when you need to buy more time to do serial mental status examination, I think during that time, you don't want to be found wanting of not doing enough. And a drug like quetiapine really fills the gap, where it gives you time to examine the patient, to see how the patient is going to respond to the up titration of something like quetiapine. So I think net, if we can monitor the side effect, if we can look at the metabolic side effects, if we can look at the QT prolongation, if we can just make sure that the side effects are adequately monitored, I think these are some of the so-called drugs which can fit into the category of designer drugs. And that is definitely the future of psychiatry, where we can move more towards designer drugs and not be found to be using too many drugs in terms of a mood stabilizer, and antidepressant, and anti-man. So like all of us are saying, we want solutions which are practical and which have minimal side effects works for our patient. And I think it should take away our anxiety in terms of being able to use it at high dosages. Very useful drug, according to me.
Right. Well, I move now to Dr. P.N. Suresh Kumar. Sir, I hope you're with us. And Dr. P.N. Suresh Kumar, sir, I am not able to see his
Yes,
video.
sir.
Yes. So one of the questions that I think one has come from the audience is that, I mean, you had mentioned about high doses of quetiapine going up to 2000 mg. That's what someone has mentioned. I don't know whether you mentioned it in your answer or so they've said that, I mean, what precautions would one take at higher doses above 600 mg if we are prescribing quetiapine at 500 or 600 mg?
See, when we talk about high dose of quetiapine in schizophrenia as well as in bipolar disorder, see, there is one study by Judy Nagy et al. This study was published in International Journal of Clinical Practice in 2014. So there, they have used a dose of 1,600 milligram of quetiapine for the acute management of schizophrenia, and the maintenance dose was 1,000 milligram per day. In another study by Bob et al. Published in Journal of Clinical Psychiatry 2002, the dose used was 1,600 to 2,000 milligram per day. Even that dose they have used for 2 years. Even then, with this high dose, no tardive side effects like tardive dyskinesia, dystonia, or tardive dysphagia, nothing was reported. But all these studies, safety, of course, these are all clinical studies, no? So they have done all the clinical safety precautions. They have done all the lab parameters profile. They have done ECG. So in all these, only minimum QTC prolongation, nothing, no severe lab deviation parameters changes have been reported. But still, what I can say that when we are using, when we are dose more than the recommended dose, we have to look for all the potential side effects like hypotension. Definitely, we have to look for. When we talk about this, see, even in a 75-year-old patient with Alzheimer's dementia, quetiapine was used in a dose of 1,400 milligram per day. But that patient, after 3 months of starting quetiapine with 1,400 milligram, he had a seizure. But he's an Alzheimer's dementia patient. He was getting carbamazepine. So we don't know whether this was due to the high dose of quetiapine or is it a part and parcel of the basic illness? We don't know. Even in Indian Journal of Psychiatry, there is a case report that one patient, because there was no improvement with the 600 milligram of quetiapine, patient himself titrated the dose of quetiapine to 2 gram per day. Like that, he was continuing quetiapine 2 gram per day for consecutively 2 weeks. Nothing happened. When the patient reported in OPD only, they found that he was using very high dose. And in fact, he was very happy with that high dose. His sleep was much improved. And this was published in the Journal of Psychiatry. I think Andrade is one of the co-authors in that case.
Okay. Right. Thank you, sir. We have an audience question for Dr. Ravi Soni. They want to know, is there any specific monitoring that you do when, more than what you would normally do if you're using quetiapine in the elderly?
Sir, when I see a elderly patient and I usually try to start on quetiapine, I always do a background check about all the comorbidities. What are the medicines patients on? So that is a brown box. I ask them all the medications, prescriptions to bring with them. And I usually ask them certain specific questions like about sleep, constipation, glaucoma, any heart condition, previous heart condition, how the patient is walking, locomotion, how whether he is ambulatory or not, and which kind of side effect can be beneficial to the patient. So like a sleep or calming effect or so many other things. Some of the elderly patients are already on diabetes medications and they are developing some of diarrhea-like conditions. So not diarrhea, but increased frequency of stool. So in that patient, if we start on quetiapine, there is improvement in the frequency of stool. They are very happy. So I'm not going to any specific monitoring through blood investigation or scales or examination wise, but I always go inquire about all the comorbidities, even if I start medicine of 25-50 milligram, I always ask them what all the side effects of the quetiapine. Specifically, we need to very much cautious about if the patient's age is more than 75. So if the patient is not having any urinary symptoms previously, but now has started, so that is we need to take care. I have seen that elderly patients have started taking more food after starting quetiapine. So appetite is increased. There is a chance of weight gain also. So in so many of my patients, I have seen that there is increased urinary frequency, increased appetite, weight gain. Uh, Also, the patient has are developing constipation with it. So apart from that, I'm not very much concerned about the side effects of the quetiapine. So this is the thing I do.
Right. Before I conclude the panel with a last round of audience questions, we have with us Dr. G. Prasad Rao. Sir, we missed you at the beginning of the panel, and we of course have specific questions for you as you're part of our second panel, which will happen after this. But any general comments you would like to make about quetiapine, just in general? We'll have specific questions for you in the panel after this.
Thank you very much, Avinash, and thank you for the inputs from both Suresh Kumars and of course Deepak Raheja, and also I don't know his name, but I heard
Ravi Soni, Dr. Ravi Soni.
Ravi Soni has given some wise pearls. First of all, I would like to mention two things. I was part of the quetiapine drug development. In the drug development, what happened is in the first few trials, I was there for the multiple trials in quetiapine, both for schizophrenia and mania trials. So initially, there was, in the first protocol, they started with 200 milligrams and went to 400 milligrams. But subsequently, the protocols have changed only because they found out this wonderful thing that if you start with 200 milligrams, patients were knocked down and hypotension is a side effect. That's why my suggestion, which I practice even to this day, is first 2 days give 50 milligrams, next 2 days give 100 milligrams, especially for schizophrenia patients. And by the end of second week, you can go to the targeted dose. I have a one or two suggestions. I know all the wise people have already given, but maybe I'm repeating some because the first part I did miss out. For schizophrenia, you should go up to 600 milligrams if there are positive symptoms. Negative symptoms, I don't mind stopping at 300 milligrams. For mania, I have the wonderful experience of using up to 1200 milligrams, only quetiapine and nothing else. And for mania, my experience now over the years is that you can start with 100 milligrams. Some of mania, acute mania patients do tolerate quetiapine very nicely. For every one of us, I'm sure we know this basic this thing, that whenever we start a molecule, we talk about efficacy, we talk about cost, and we talk about side effects. So cost, I'm not really considering, but side effects wise, both mania and schizophrenia, quetiapine is a good drug too. Only thing is, I have seen, and I think our panel did suggest, including Sony, that, and there are even my young friend Deepak Raheja has talked about using quetiapine for sedation. That is the unfortunate thing, according to me. We can still use as a good indicator, but primarily it is meant for three important conditions, according to me: schizophrenia, bipolar mania, and bipolar depression. This is one wonderful drug for depression, and I think everyone covered. For depression, I normally go up to 300 milligrams, and as everyone, I think my friend from Chennai, Suresh Kumar, because there are two Suresh Kumar in this group, has already highlighted that I have used. One last thing which I would like to highlight is geriatric usage of quetiapine for me, especially BPSD. My PhD is on BPSD and dementia. So over the last 4 years, I've been collecting a lot of patients of this and managing them. Quetiapine is a much better drug when compared to risperidone. So that's, of course, my personal insight. And I'm sure Suresh and others would comment on whatever I said if they want.
Right. Thank you so much, sir, for joining us. We'll see you soon in the next panel after this panel ends, where you will be a part, and please be with us. There is one audience question for each of y'all. So I will, of course, start with Dr. Suresh Kumar. Sir, the audience question that has come in for you is that quetiapine combined with sodium valproate versus quetiapine combined with carbamazepine or oxcarbamazepine? What is your take?
Carbamazepine, for a variety of reasons, is not utilized by many practicing psychiatrists because they are very worried about its what it can do, not only in terms of the word Stevens-Johnson syndrome, which is more likely than with sodium valproate, but I think the real reason is of the drug interaction. It actually halves many of the efficacy of other drugs. That's one of the reasons why carbamazepine has become very unpopular. But oxcarbamazepine is an underutilized drug even among psychiatrists. I think younger psychiatrists are actually taking to oxcarbamazepine more than the older psychiatrists, but I think rightfully so. Oxcarbamazepine may be very, very useful in many of these cases because, sodium valproate, unfortunately, is an excellent drug. Valproate and sodium valproate is an excellent drug. But for certain populations, you cannot employ it. Women with the reproductive age, it's kind of, like no drug. And the side effects of valproate can also be intimidating to people, loss of hair and, other things, weight gain could be very intimidating. So I think even though many people, if you really look in terms of efficacy, you'll vote for valproate or sodium valproate. But if you are really wanting to be considerate with some of your clients and not to have so much of a side effect burden, oxcarbamazepine wouldn't be a bad choice.
Right. Amrit, audience question for you. Is there any role of a quetiapine aripiprazole combination in OCD?
Well, that is, I feel that is too far-fetched.
Right.
Without any antidepressants, you want to add quetiapine.
No. They are saying as an augmenting. I mean, they already would give fluoxetine or some first line or clomipramine or whatever. But would you give a quetiapine aripiprazole combination? Sorry, in OCD with poor insight. They've asked.
Yes. So you're looking at the delusional part. Sometimes when it is difficult to tease out whether it is psychosis or whether it is a OCD or whether it is delusional in nature.
Yes.
I think it's not a bad combination in terms of, if you look at the profile, both are second generation. Generally, we would think twice before we add two second generation antipsychotics for OCD, be it with poor insight or with good insight, because primary treatment will be SSRI or maybe a clomipramine. So that is the primary treatment. Secondary point, if you want to add antipsychotic, yes, both will act good because aripiprazole causes a lot of akathisia, which quetiapine will take care of. Number two, aripiprazole is weight neutral, and quetiapine, it will offset some of the weight gain that we get with quetiapine. Aripiprazole has no sedative action. Quetiapine has sedative action. But to be honest and to be very fair because people are listening, I have never thought of this combination.
Right. Well, thank you. Dr. Chawda, sir, there's a question from the audience. One is the weight gain seen with quetiapine in children and adolescents, is it far less than what you see with risperidone? One. And second, would you consider quetiapine as an alternative if risperidone is not tolerated in conduct disorder?
Yes to both.
Okay. Thank you. Dr. Deepak Raheja, so there's a question asked to you that with so much of a conundrum with regard to benzodiazepine use and misuse by general practitioners, do you think we should encourage general practitioners to use quetiapine 25 mg as a sedative rather than using benzodiazepines? I don't know who's asked it, but someone has asked it specifically for you.
It's a very, very tricky question in terms of what they should be encouraged to use. But I think if we are specifically talking about GPs, general practitioners, I think they'd be happier just using benzodiazepines that they use any which ways. And I think the use of drugs with precise know-how, I think, should be left to the bastion of psychiatrists and should be our bread and butter. Because up titration, monitoring the side effects, and also not just that, very intricately understanding the nuances of when to use it. See, I mean, to type in, I agree with Dr. Prasad Rao when he says we should not belittle it to just firing a bullet when when in the wake of not knowing what to do. It should not just be a non-specific sedative. It can't be a non-specific sedative. It is a drug which can be used in that low dose, as some of us have said, but with precise understanding of underlying. And I've often seen that underlying comorbidity is an access to comorbidity, which is not usually responsive, and those patients have definitely a huge risk of abusing the benzodiazepine. So I think there the quetiapine has a role to play, but I think the nuances of understanding that come across as very simple to us, but I think in general practice, it's not so simple and easy, so shouldn't be belittled.
Yes. Dr. Ravi
Avinash,
yes.
Avinash, can I put a question? I have not written it in the chat box. Just one question. Is it permissible?
Please, sir. Yeah.
Okay, this is for Dr. Karsi. Dr. Karsi, what is the role of quetiapine in ADHD? In some literature, recommend it in ADHD. What is your take on it?
Sir, I have dealt with a whole bunch of ADHD. I don't think I've used it profusely at all. I would much prefer to use the stimulants and either use aripiprazole or risperidone rather than quetiapine. I have not really used it in ADHD. Even, yes, I agree there is a lot of literature which says that it can be used, but I have not personally used it.
Right.
Yeah. Thank you so much.
Thank you, sir. Thank you.
Dr. Ravi Soni, two quick questions for you. Quetiapine in the elderly, how often would you do an ECG? That's one question which someone has asked. And second, and particularly even if there is, and particularly if there's a history of, some cardiac morbidity, I mean, would you do that? And have any experience in using quetiapine above the age of 90 years? I don't know why someone has asked this, but they've asked you.
Answering the first question, I'm usually practicing geriatric psychiatry. So the reference work to me is usually last resort for me. So patients come after visiting so many psychiatrists, they are already doing their cardiologist follow-up. So they are always having an echo and ECG with them. So I usually satisfied with that.
Correct.
And if I want to use quetiapine for an indication that requires higher doses, I will ask them to go for a ECG after 1 or 2 months. Otherwise, I usually do not go for ECG monitoring in an elderly patient. And second part, I have not used quetiapine in an elderly patient beyond 90 years because it is very difficult and there are so many side effects. So quetiapine is dangerous if you want to use in a patient of more than 90 years of age.
Dr. P.N. Suresh Kumar, sir, quetiapine high dose versus olanzapine high dose. I mean, metabolic syndrome is greater in what? That's what the audience has asked. Quetiapine 600 to 800 mg versus olanzapine 20 to 40 mg. Metabolic syndrome risk is higher in which group?
Definitely, there are studies comparing efficacy of olanzapine versus quetiapine in bipolar disorder, as well as in schizophrenia. So in all these studies, they have in a head-to-head comparison, what they have found that all the metabolic dysregulation, including glucose and lipid dysregulation, including the increase in BMI, weight gain, all these are much higher in olanzapine, 15 to 20 milligram, versus quetiapine 400 to 600 milligram per day. So that's why we are saying that especially in obese ladies or in gents also, whenever there is especially in diabetic patients already existing dyslipidemia, the ideal drug would be quetiapine versus olanzapine. So when we are starting any antipsychotic, we have to have a baseline workup. So if there is a pre-existing obesity, pre-existing dyslipidemia, weight gain is already there, it is better to go for, compared to olanzapine, it is better for quetiapine.
Right. Well, I think that brings us to the end of our first panel. So Dr. M. Suresh Kumar, Dr. Amrit Pattojoshi, Dr. K.C. Chawda, Dr. P.N. Suresh Kumar, Dr. Ravi Soni, and Dr. Deepak Raheja. It's been an absolute pleasure to be a moderator to such an eminent panel. And I thank you so much for being with us. We love you all. So if you could stay with us, of course, till the end of this program, nothing like it. But if you do have other duties and other places to go, it's Saturday evening. So we will definitely excuse you all. So thank you so much for being there. And we will now move to our second panel.
Thank you.
Thank you.
Avinash,
Thank you.
Thank you so much.
Yeah.
Thank you.
We will now move to our second panel, and our second panel, of course, is consisting of a very eminent group of panelists, and I will, of course, we have, of course, with us, yes, Dr. G. Prasad Rao is here, Dr. Jayanta Das and Dr. O.P. Singh, Dr. Mahesh Gowda is here, Dr. Sudhir Bhave is also with us. Yes, so I will start off with Professor Dr. P.K. Dalal. Well, sir, what is your opinion with regard to, say, quetiapine as a first-line drug in schizophrenia in combination with maybe any other antipsychotic?
I mean, you see, there are many studies out there which show that monotherapy is best, right? So before adding any other molecule, it will be important to use any molecule, as has been said, for its adequate dosage and adequate period of time, right? And then you can see to it whether there is response or remission, and accordingly you can adjust the dose, or you can go higher up, or you can discard if there is partial response even at a higher dosage. One can really think of adding another molecule, but the studies, they say that probably the best outcome is with monotherapy. But otherwise, you see, if there are certain depressive parameters are there, we all know that quetiapine in low dosage can will be a good kind of an antidepressant as well, antidepressive action as well. So in low dosage, well, at times schizophrenics, they may have more of a, I would not say negative symptoms, because there is no drug as yet which is the drug for negative symptoms or for cognitive symptoms. So we can be choosy about it and can add quetiapine in low dose if at all required. But we will have to be very careful if there are addition in side effects or not, if there are any other, say, sedative effects, or maybe other metabolic side effects are there or not, if adding quetiapine with it.
Right.
Well, with the I mean, if one requires in a psychotic patient, if one requires to have some sleep problems, then one can really add quetiapine in low dosage. If there are certain, I would say, depressive symptoms, then one can add quetiapine. So in this way, can add on can go along with that.
Right, right. I now move. Okay. I now move to Dr. G. Prasad Rao. So, what, according to you, is the role of quetiapine in mixed states, particularly? Yes.
Thank you, Avinash. Dear esteemed panel members, especially Dr. P.K. Dalal, our honorary president, and O.P. Singh, our honorary editor, and my young friend Mahesh. It's a pleasure to be a part of the team along with Jayanta, my elder brother there. I think I sincerely appreciate Dr. P.K. Dalal's response. I think there is no real advantage if you are looking for it. Before I answer my panel question, I would like to add on to what P.K. Dalal said. Yes, the evidence is overwhelmingly that monotherapy or polytherapy does not have any advantage, evidence-based on the monotherapy. But still, we in our country use rational or sometimes irrational combinations for targeting some doses. That way, I think quetiapine has been used both for sedation and depression also. And depression, I would think the dose need to be reached in schizophrenia at least is up to 200 above, usually till 400. Now, coming to mixed state, my experience with quetiapine, especially in the subtle depressive symptoms, quetiapine and I used very extensively both in lithium and quetiapine combination and divalproate quetiapine combination. And I would say the percentage of people in mixed who have hitherto not responded. There is another favorite combination I use is OFC, olanzapine, fluoxetine. But quetiapine somehow, along with lithium, has been one of my favorite combinations, along with divalproate. So you like it or not, 15 to 20% of our patients do not present with either a clean manic episode or a clean depressive episode. In depressive bipolar depression, one of the preferred drug is quetiapine in my experience. And I would agree the evidence has been, as you know, US FDA's first approval apart from OFC has been quetiapine among the atypicals. Following that came lurasidone. So logically, I think that's the best drug for me in my experience.
Right.
And in mixed, the only problem probably is how to up-titrate. And in the previous panel, I did talk about, I normally start with 50 milligrams for the first 3 days and 100 milligrams for the next 3 days. Then I shoot up to 200 milligrams, wait for 1 to 2 weeks, and then go further up to 300 milligrams, depending on the response. But the problem always is in a mixed, you need to use this quetiapine for a much longer period. Usually my experience is about a year and more. And this is definitely a different subgroup, which DSM-5 also is still studying whether to retain or not to retain, because the pharmacological evidence has not come out. Otherwise, as an entity, there seems to be an agreement.
Right. Thank you, sir. I now move to Dr. Jayanta Das, who, again, I always like to say that he's just like a father figure to me from Guwahati. Well, sir, what do you think is the role of quetiapine in somatoform disorders? Does it have any role particularly in those group of patients?
You see, my experience, I'm talking from my perspective. I am not great prescriber of quetiapine so far the somatization disorder is concerned. My first take is on bipolar depression, quetiapine, okay. And my second choice in prescribing quetiapine is patient with dementia having behavioral problem or having psychosis. And as Dr. G. Prasad Rao has mentioned, I find it is a great medicine to control the dementia. And in fact, in a previous panel discussion, there was a query whether Dr. Ravi Kumar has used above 90 or not. And recently only a patient from 90, almost 90, probably he was 90 plus. I hesitantly started 12.5 only, this quetiapine, and I found a great result from that patient. And he maintained, even at 12.5, a 90 plus patient is maintaining very well. So far behavioral changes are concerned. So for the somatization, somatic symptoms are concerned, it is a lot of literature, they recommended that somatization symptoms can be controlled in comparison to venlafaxine or other antidepressant in a very low dose. But I still feel that it cannot be a great choice for somatization, somatic symptoms. And so far my experience is concerned is very, very limited. Only recently I have added a few patients of agitated and generalized anxiety disorder patient with escitalopram, SSRIs, and very small dose, small dose of quetiapine. And 3 or 4 patients of those patients are doing wonderful. Previously they were in paroxetine, and suddenly I somehow changed it to escitalopram and combined with low dose of quetiapine, and I found great results. So, and I have not used it. So for the somatoform disorder is concerned, and a subset of group is conversion disorder can be included in that. Although there are literature recommending the quetiapine in conversion disorder, from my experience in this regard is very, very limited.
Right. Thank you. I now move to Professor Dr. O.P. Singh. And sir, in your experience, 2 questions. One is, what is the Indian literature with regard to quetiapine, and the role of quetiapine in pregnancy and lactation? I mean, is it safe? Is it unsafe? Yes.
First, the Indian literature. Since a lot of trials were done in India also when quetiapine was launched, and also for other purposes. So initially there have been robust literature from India, may not be published in Indian journals, but a lot of centers were in India. So there is a lot of Indian experience. And furthermore, there are some studies, like one study comparing quetiapine with clozapine in treatment-resistant patient, and also one study comparing olanzapine and quetiapine from India. So there are a few studies. One study also compared sexual side effects of risperidone, olanzapine, and quetiapine in IJPM. That what were the sexual side effects with these drugs, and found no statistically difference. So these are some of the studies, and there are a lot of case reports. Every side effect which occurs with antipsychotics has been also described with quetiapine, including NMS, including dystonia, uh, including EPS. So all these things are, there are case reports on this. So this is about the Indian literature. Coming to pregnancy, you know that pregnancy is very important in the sense the psychiatric disorders itself is a major risk factor for the fetus. If they're not treated properly, there are high chances of abnormality in fetus. That is one thing. Second, the in for female mother, the most of the drugs volume they need in higher doses because their volume expands. There are other metabolism increases, so we need to give higher doses. But for the children, for the fetus, their system is liver is not functioning properly, kidney is not mature, so their effect on fetus is very high. So we need drugs which do not pass the placental barrier very easily. And here somehow they are in Indian Journal of Psychiatry review by Prabhat Chandran guidelines. They've said that risperidone and quetiapine has been found to list, that is list crossing compared to all these atypicals, and particularly that protein PSPG, which has been found, which prevents there have been high substrate for this risperidone and quetiapine, which prevents their passing to the fetus. So it is a quite safe and it has been used. Personal experience is also very good. Quetiapine used in pregnancy. Of course, we have to monitor for more for blood glucose levels, which are likely to shoot up in pregnancy anyway. So monitoring has to be more frequent. But this is an excellent drug to be given in pregnancy, and it is well tolerated. And breastfeeding also, it is very safe. Olanzapine, risperidone, quetiapine, both all three are negligible below the critical value of 10% in the milk. So safe in pregnancy, whatever it may be, whatever the safety we can have, and safe in relatively safe in breastfeeding also.
Right. I now move to Dr. Sudhir Bhave, who has, of course, joined us from the Orange City of Nagpur. Well, sir, in an era where typical and atypical antipsychotics are often combined in clinical practice, I mean, in your experience, has there been any usefulness of a haloperidol-quetiapine combination?
Yeah, I would say that I have used a combination, and the combination I have used in cases where quetiapine was started as the primary drug. In both, I've used in both in mania as well as schizophrenia in fair doses upwards of 400 milligram per day. And when these kind of doses did not help, then or helped only partly. So with a partial remission and a continued dosage when there was no further improvement, I do tend to add a first generation, because I think it is by and large agreed that if at all you have to combine two non-clozapine antipsychotics, it better be one first generation and another second generation. So I have used quetiapine with haloperidol, and I must say that there are quite a few patients whose response to treatment increases when I've used these two drugs together. Now, this might hold true for drugs other than one is FGA, one SGA, other than these two. But then this combination I have found to be particularly useful. Earlier, when quetiapine came, I did use that with haloperidol at times as a hypnotic, like because of this highly sedating action. But later on, I came across studies that even low dose quetiapine can have negative metabolic consequences. So I stopped using that. And I have used this combination in those rare cases where patient is getting haloperidol, gets a significant extrapyramidal side effect. Trihexyphenidyl was added, But then it becomes a kind of balance between extrapyramidal symptoms on one hand and side effects of trihexyphenidyl on the other. Like middle-aged patient who develops confusion on adding trihexyphenidyl. So in these cases, I found it prudent to lower haloperidol and then add quetiapine, which has a low EPS potential.
Right.
So that was the second use of this combination that I found. So I am quite okay with this combination where clinically indicated. Yeah.
Right. So, and since we are on the typicals between haloperidol and trifluperazine in combining with fluoxetine, I mean, what would, with quetiapine, what would be, your choice, haloperidol or trifluperazine?
Now that you ask this question, my choice would be trifluperazine.
Okay.
It depends to some extent on the clinical profile.
Right.
Like if there's a patient who is more likely to develop extrapyramidal side effects, if there is a middle-aged female patient who is more likely to develop tardive dyskinesia, it's TD is more common in females, who are beyond 40. So it depends on the individual case, but I think looking at the safety profile and hardly any difference in the effectiveness profile, I would go for trifluperazine as the first choice.
Sure. Thank you, sir. I now move to Dr. Mahesh Gowda. Sir, in your experience, have you used a quetiapine amisulpride combination and have you found any pros, cons?
Thank you, Avinash, for the question. I think when you come to combining drugs, there's a scope for combining any drug based on a rationale. So if you look at typical, atypical, we've been combining a lot of medications. But here, if you look at quetiapine and amisulpride, it's not one of the favorite combinations by most practitioners or literature support also. But however, there's a scope for combining this sort of drugs. They seem to add up in some way because of receptor potency and in terms of sensitivity that they have. Sometimes we try and combine to make it cost effective. And if you look at the rationale, why we generally add on amisulpride, it could be as an add-on, it could be for augmenting or just to make it a combo to make sure we get a better symptom control. My favorite combination still would be quetiapine and risperidone, not so much of amisulpride because when you look at costs, it does not seem to be adding up. Sometimes we cut down the dose of quetiapine and add risperidone just to make sure we are adding up this medication to get the more robust efficacy there. Quetiapine and amisulpride is not so favorite combination of mine, but definitely there's a scope to combine these sort of drugs when such sort of clinical scenarios arise. Thank you, Avinash.
Thank you. I now move to Professor Dr. P.K. Dalal again. Sir, a general question that Dr. Dalal, sir, are you with us?
Maybe it's not there.
Yeah. So okay, so we'll go back to him later. I now move to Dr. G. Prasad Rao. So what is your take on a quetiapine clozapine combination or a quetiapine risperidone combination?
First of all, I should appreciate Avinash the way he questions in this seminar, where he puts all kinds of combinations and picks up an opinion. Now coming to the two combinations which you mentioned, quetiapine clozapine combination probably not a very favorite of mine, but quetiapine risperidone combination has been a good combination. As I said in my initial remarks, there are some rational combinations and irrational combinations. Irrational, when I talk, we are talking about irrational in terms of the so-called drug-to-drug responses. Practically, there are no evidence-based rational combinations as we know. Except for clozapine, we have evidence for risperidone. But clozapine with quetiapine has been one of the combinations. You might ask, they both would add to sedation. But I have a pool of 6,000 patients on clozapine. Among them, a few percentage, about less than 15%, were receiving quetiapine. You might ask why. There is a certain peculiarity in this kind of a combination which I found. The clozapine I was using, and I was also getting the blood levels done. The clozapine, I need to use only 150 milligrams to 200 milligrams, unlike 300 milligrams for only clozapine. This we have to resort for something. But I think the combination of quetiapine risperidone is far more percentage as a combination. Here, I normally use whenever there is an affective depressive component coming as a part of the syndrome in schizophrenia patients, or some difficult bipolar patients where we use this combination. In fact, it has been my favorite in bipolar mania, quetiapine usage, along with mood stabilizers or without mood stabilizers. In fact, one of the combination, quetiapine and risperidone combination, there are quite a many few patients. Though it might sound illogical from the pharmacological point of view, it is logical because 300 milligrams of quetiapine and 4 milligrams to 6 milligrams in mania, it works in both ways. And somehow I found that this combination, that patients did not complain much of sexual side effects. For some reason, there is some drug-drug interaction. But again, sincerely appreciate Avinash's homework and the way he asks questions, so that he doesn't miss both the typical and atypical and the very quite odd combinations. Now, my dear friend PK Dalal has come. Now you can shoot the question to PK Dalal Saab. He's ready to answer your questions. In between is, I've seen him munching something.
Dr. Dalal sir, we have a question for you that in the Department of Psychiatry at KGMU, what is the general prescription pattern of quetiapine? I mean, what dose would you start and how would you up titrate? That's a question which we would like to ask you. And is there anything specific about quetiapine that you would want to highlight in psychosis?
No, we generally... Just a second.
Yes, sir. Yes, sir. No problem.
Yes. So basically, being in government institution, the patient profile which we get is because of the cost of quetiapine, we generally do not use as a you can say monotherapy in schizophrenia, where the dosages are between 400 to 800 milligrams per day, because of the cost. And we primarily use risperidone or olanzapine, so which takes care of that. In as I have already said, that in low dosage we can use in psychosis, especially in schizophrenia, if there is depressive symptoms, or if we want that the person is not sleeping, if we want it in some nighttime dosages. So maybe in low dosage up to 300 milligram. And 300 milligram is generally the dose for bipolar depression as well. So we use it. In depression, unipolar depression also, the dosage as an adjunct is generally between 150 to 300. And it is said, and we have also seen, that lower dosages are probably preferable, that is near about 150 to 200 milligrams. Bipolar depression, yes, there are studies which have compared between 300 and 600 milligram, and they have not found much of a difference. Right. And similarly, in unipolar depression, they have found, they have taken two groups, 150 and 300, and they have not found much of a difference. So lower side of the dose in unipolar depression and in bipolar depression are around 300. That is the dose which we generally use in our institution. We often use it, this molecule, in very low dosage in dementia with behavioral problems, or with micropsychotic episodes kind of a thing. We generally begin with 25 milligram half tablet. And then gradually, as the dictum says, that start low, go slow, then we gradually try to build it up. Right. And again, 100, 150 milligram is good enough a dose to take care of all these behavioral symptoms or micropsychotic episodes. That is the dosage when we use. At times, if the person is affordable and he says and he is having side effects or doesn't tolerate olanzapine, risperidone, and maybe not responder or partially responder, if we have to choose upon, then we can go, we use quetiapine, of course, between 400 to 800 milligrams in schizophrenia. But I would say that is infrequently.
Right, right. Thank you, sir. I now move to Dr. Jayanta Das, and sir, with whatever quetiapine use you have in your practice, are there any specific drug combinations that you like to use quetiapine with?
Say, in case of bipolar, of course, if I have to combine with a mood stabilizer, I'd always like to go with lithium or even sodium valproate, whatever it may be, depending on the individual this thing. So that is one choice. And so for psychosis is concerned, I mean, in that case, of course, usually I always believe in first monotherapy, one. But if I have to combine it, risperidone and quetiapine is my choice. Maybe sometime risperidone is amisulpride, but since quetiapine you are asking about, I'd go with risperidone and quetiapine.
Okay. Right.
And in case of generalized anxiety disorder, with SSRIs, any SSRIs, maybe fluoxetine or acetalopram, generalized anxiety disorder, or even it is nowadays recommended for PTSD, etc. But as I mentioned earlier, in somatic, I have not great experience about this. Right. Although it is recommended that low doses always works. In, of course, dementia with behavioral symptoms and micro, as Dr. Dalal has mentioned, micropsychosis, I always go slow, and I always start with 25 milligram half tablet, sometime starting at a nighttime dose, and then gradually expanding into twice BD doses, and then gradually 2-3 days interval. I'd like to get information from the patients and like to go up along with them.
Right. So another question, since it's an audience question, I'm posing it to you. In a young adult male between the age of 20 to 25 with a brief psychotic episode, which is less than 2 or 3 weeks, would you use quetiapine as a monotherapy?
No, I'd like to go for risperidone.
Okay, right.
That is my choice.
Yes, right, sir. I now move to Professor Dr. O.P. Singh. So there's one audience question for you. In a drug-naive lady who's pregnant and psychotic, what would be our choice? Olanzapine, risperidone, or quetiapine?
No, first is that, thank you. This is a very interesting question. That drug-naive first episode and clozapine versus this.
Yes.
Because clozapine is safer.
Yeah.
But again, I will not starting clozapine de novo. Reason being, if the patient is resistant, then on the clozapine, then we will continue it because it is more safe compared to these drugs in pregnancy. But problem with clozapine is I want to prescribe a drug which I can continue in breastfeeding also. So clozapine I have to stop while breastfeeding. So I have to change it. So if the first time comes and if there is no special indication for clozapine, I may choose from risperidone, olanzapine, or quetiapine. Maybe olanzapine, or I will prefer depending on things, or risperidone, or even quetiapine. So that is the thing. So even if safety profile of clozapine is much better in pregnancy compared to these 3 molecules, I have to think of other factors and continuation after the pregnancy in breastfeeding also. So in first episode, there is no extra indication. I will go with these drugs.
Right. And so do you think there's any role for quetiapine in the management of anxiety disorders? Does it play any role in a low dose?
Already Dr. Das has talked about it. It has been approved for depression as a monotherapy. In anxiety, for our problem is that whether to prescribe benzodiazepine or not. Efficacy-wise, clozapine has been found to be effective, but not as effective as SSRIs in anxiety. This is the basic thing. It is better than placebo, but SSRIs are more effective. But what happens when we give SSRIs, the initial anxiety do not lessen. And a lot of the patients are there who are almost agitated beyond a level when you are not able to control. And their choices are high doses of benzodiazepines, and then or quetiapine. Again, the depending potential of benzodiazepines is there. So there, though it is off-label use, in combination with this, quetiapine has a role, particularly in patients who are more anxious, agitated kind of picture is there. So there it helps, of course, in the combination of with SSRIs.
Right. Thank you, sir. I now move back to Dr. Sudhir Bhave. Sir, if you have a patient that's maintained well on quetiapine, and the sedation and lethargy is the only side effect that he's facing, but he's otherwise doing very well, would you choose to add R-modafinil, to counter the sedative effects, or modafinil to counter the sedative effects of quetiapine?
Yeah, see, practically speaking, I have used quetiapine causing sedation and R-modafinil added. Now, if you look at the theory, it says something different. Like they have done studies where R-modafinil was added to quetiapine, and they have shown that because of the drug, there is an interaction. Because of the interaction, pharmacokinetic variables like area under the curve, the Cmax, they decrease for quetiapine. So thereby that should reduce the efficacy. But then clinically, I have not seen that really. In whatever cases I have added R-modafinil, the effectiveness did continue. So yeah,
yes.
Going by my own experience, I do.
Yes, yes. And so quetiapine, higher doses versus lower doses, your experience?
Yeah. Now, higher doses naturally give rise to more side effects like somnolence or sedation. And I have somehow seen that if I use higher doses, say doses in the range of 600 to 800 milligrams per day versus about 300-400 milligram per day, I personally have not found much difference between the clinical effectiveness in these two dose ranges. In fact, when I saw this observation, I went through literature and I did come across interestingly, two randomized controlled trials which showed that effectiveness wise, there is no difference, even though side effect wise there is. So for my own use, I generally don't go for higher doses.
Right. So there's an audience question for you. I mean, patients don't tell, and we sometimes don't ask. But have you seen any sexual side effects with quetiapine?
Not in my experience.
Right, sir.
Having seen that.
Right, sir. Thank you. I now move back to Dr. Mahesh Gowda. So with regard to quetiapine, how much weight gain have you noticed versus olanzapine and risperidone?
Actually, if you look at the literature support for side effects and weight gain related issues, somehow quetiapine has actually had a very favorable response. The most preferred drug would be something like risperidone and quetiapine as far as weight management is controlled. Olanzapine and clozapine are the shunt drugs, and if you look at the indication also, somehow the people who are on indications of schizophrenia or related psychosis related issues are the people who tend to gain lesser weight compared to people on bipolar disorder, because they tend to be on combination. Somehow the weight gain is also adversely impacting the outcome of studies also. There's a lot of studies like KT study which actually talked about poor outcome when people gain a lot of weight. And weight gain in quetiapine is something that we must be comfortable with, simply because short term there's something that we must watch out for, like 1 to 3 kgs of weight gain. But on a long term, somehow this seems to even out the advantages and the benefits of quetiapine use, and the restoration of the quality of life and the functional recovery that happens finally will make them more functioning, and the weight gain somehow seems to even out. On a long term, whether it's bipolar or schizophrenia, I think we must be comfortable with using quetiapine and not be worried about weight gain quetiapine related issues.
Right. So same question for you again. Is there any role of quetiapine in patients with the so-called schizo-obsessive symptoms?
Somehow this is a very difficult combination. It's a hybrid model of schizophrenia and bipolar and OCD for us, and not so common. This is 1%, that is 3 to 5%. Somehow it's not a very commonly made diagnosis. But if you look at the symptom profile of people who respond on the PAN scale and the OC symptoms scale, people with dementia having this sort of obsessiveness, perseveration also respond to quetiapine as a monotherapy alone. Coming to schizo-obsessive disorder as such, there is a lot of role for using primary standalone atypical antipsychotics, and more so like quetiapine in schizo-obsessive disorders. But when in difficulty, we definitely need to give the benefit of an SSRI and add on there. But there is a role. I couldn't find any double-blind, randomized, placebo-controlled trials to say that this is the indication and this is found to be useful when compared to placebo or any other comparator. So it's from what I really see in clinical practice is what I'm trying to tell you.
Right. Thank you. I now move to Dr. G. Prasad Rao, and we have 2 audience questions, sir, for you. Dr. Prasad Rao, sir, you're with us. Dr. Prasad Rao. Okay, well, Mahesh, there's an audience question for you. I mean, have you seen quetiapine abuse in your practice?
Quetiapine abuse, somehow I think very rare. I've had some people who've taken 2 times of the dose what I generally prescribe for reasons of sleep and feeling better in control. This is one of, or maybe 2 or 3 cases in the last 15 years of my work in Bangalore, but not a very common phenomenon. It's not like a benzo, right? People don't like that sort of knocking down effect of quetiapine compared to a benzo. So
Right.
not a very commonly abused drug. I think it's quite safe to be used and very less dependence potential.
Right. Well, I have two. Yes. So we have 2 questions for you,
I'm
Dr.
there.
Prasad. Yes, Dr. Prasad Rao. So we have 2 questions
Yeah.
for you. One is, does quetiapine have any role in a patient with treatment-resistant schizophrenia where clozapine has to be discontinued for some reason? That is one. And second, quetiapine immediate release versus sustained release. Have you found any differences in the treatment? Yeah.
I'll answer the second question first. Actually, quetiapine immediate release is useful, as a lot of our colleagues in the previous panel also talked about, for sedation, for a small dose effect, for example, in autism, because the children do behave differently. And in geriatric population, especially, I had a quite lot of experience in BPSC, especially, where quetiapine can be used as low as 12.5 and go upward. Now, there is a difference between immediate release versus sustained release. In pharmacokinetic, sustained release roughly takes about 6 days to really stabilize. Though the evidence has shown by 4th day onwards, you get a therapeutic window, reaching the therapeutic window. But immediate, our clinical indications obviously is different. Here we are giving mostly for sedation, and I think for that it works immediately. And we are not looking for, and mine, see, I have seen some OCD patients where we give only very low dose. You don't want our patients who are on SSRIs to sleep during the day. That's one more area where you find a difference between immediate release and sustained. Many times we start at 25 milligrams, go to up to 75 milligrams in a severe OCD with severe, you can say so-called psychotic. But the second question is more tough. Quetiapine versus the kind of, I don't really have experience on that.
Right.
Immediate release and sustained release.
Right, sir. I will move to Dr. PK Dalal, sir. And sir, I have just there's one question from the audience that would you, recommend quetiapine as an augmenting agent, say, with SSRIs or SNRIs in depression?
Yes, if it is recommended also. That is, if there is a partial response, right? And so as I told you that there are studies between 150 and 300 milligram, and they did not find much of a difference. So one can gradually build up to 150 milligrams, and it has shown adequate response. If the patient is on SSRI and having, as has been said, having jitteriness or having more of a increased amount of anxiety or all these things, then of course one can go for a low dose kind of a thing. Or if there is sedation is required, then immediate release, as has been said, that can be given in low dosage. So all these things are actually these are all the recommendations.
Right.
But as such, if there is a partial response, then it is very well documented that as an antidepressant you can definitely go for an add-on.
Right. Thank you, sir. I move to Dr. Jayanta Das. Sir, there's an audience question that since in the Northeast we see a lot of substance abuse, it's been reported, that's what they're saying. Do you all use quetiapine as a sedative in substance abuse withdrawal or in substance abuse patients?
Not exactly. In some cases, yes, but then as a sedative, although Dr. G. Prasad has mentioned and given in one statement that it is very unfortunate to use quetiapine as a sedative, but at times I find it is quite helpful, to use it as a sedative. In that case, of course, substance abuse disorder, we can definitely use it, as a sedative.
Right. I now move to Dr. Bhavesh.
Before Avinash, I just want to clarify.
Yes.
Jayanta bhai, what I said was majority of psychiatrists were using low dose quetiapine only and not using the therapeutic for the given indication.
I see. Okay.
Right.
I got it. Thank
As a
you.
sedation, as a good sedative, quetiapine has its own place, well established, much more than zolpidem.
Right.
And
Exactly.
and it
Yes.
has a
Right. Dr. Bhave, sir, question for you is, if you have a young lady between the age of 18 and 30 who presents with schizophrenia, risperidone versus quetiapine, what would be your choice?
I think that would be quetiapine.
Right.
Hyperprolactinemia is not at all less common, and in fact,
Right.
we see a large number of problems associated with hyperprolactinemia.
Right.
You know, the entire list, and including
Right.
things like infertility. So for me, any day it's quetiapine if the patient is able to tolerate the sedation.
Right. Dr. O.P. Singh, sir, question for you is, would quetiapine have a role in the schizophrenia prodrome? I mean, if you don't want to start heavy antipsychotics, would you start with quetiapine at a low dose, and do you think it would work?
I will go into different trajectory, okay, to answer this.
Right.
First thing, we have to determine that whether antipsychotic is required or not. Why we are giving quetiapine?
Right.
Because in prodrome, whatever the studies are there are two kinds of molecules which are helpful. One is omega-3 fatty acid and kind of antioxidants, which are helpful. And second are SSRIs are helpful if you take care of anxiety and depression. Those patients do not go and change to schizophrenia. But if you think that prodrome is diagnosable, we are sure that it is a psychosis, then we can go with the full benefit of antipsychotics in full dose. So we have to determine that.
Right. So I have a question to both Dr. P.K. Dalal sir and Dr. G. Prasad Rao sir, being presidents of our two major psychiatric associations. And this is a question which came up in the last panel, but I would want to put it to you. And I think it was a question which was asked, I think, by somebody who wanted to know that with so much of our I would say emphasis on, not prescribing benzodiazepines too often and not allowing the misuse of benzodiazepines happening. Do you think we should educate general practitioners to use quetiapine in low doses as a sedative rather than use benzodiazepines?
May I answer first, or our learned president will answer?
Our universal president first.
PK, you love me so much that you call me universal. Okay. My response would be it's a little premature at this point of time. All said and done, the benzodiazepine use is much more by psychiatrists. It's also used by GPs, physicians, and other specialties. I have figures over the last 9 years now consecutively. And I have the prescription patterns of 400 psychiatrists every month for the last 8 years. What it goes is every psychiatrist prescription, almost 90% has one benzodiazepine. So but the point is very well taken. Like the real benzodiazepine abuse occurs in less than 5%. That's my general pitch. Abuse means taking medicines beyond our prescribed dose as an addictive. So I think educating, the point is my first priority as a leader of Indian Psychiatric Society to each one of the persons who are training the trainers, that is GPs and physicians. First, make them use appropriately antidepressants and benzodiazepines appropriately, because that part has not at all percolated to quite a lot of IMAs. Wherever you go to IMAs, they still talk about, something which is, you find it totally irrelevant, because that's what they are education in undergraduate. I would still think the time has not matured at this point of time. So whatever our wonderful guidelines are, our benzodiazepine usage by our own colleagues is still high, very high, because I think I've seen, there was one prescription, one doctor's prescription I was following for the last 12 months. Each time the benzodiazepine dose is more or less same at 1 to 1.5 milligrams of clonazepam, or equivalent of that in the combination. So I think each one of us becomes sufficiently good psychopharmacologists by experience, and experience matters quite a lot. As Jayanta, the most experienced in this group, along with P.K. Dalal, would agree that we cannot say we will not write benzodiazepine. Most depressive patients have anxiety and they need an good proper antidepressant. And quetiapine that way is a good sedative, but not a good anti-anxiety that they use. And again, the dose needed for anti-anxiety is about 75 milligrams, which once we prescribe, there will be a lot of other issues. But I would definitely say, Avinash, this is a very wonderful question.
Yeah. So
what I would like to say is that if you really want to use it as a sedative, means what? That you are using it for nighttime dosage.
Right.
If you mean that,
yes,
as a hypnotic rather, then I would first try to tell our GPs to first know what is sleep hygiene.
Right.
That is number one. And number two is to use zolpidem in proper dosage.
Right.
If the person is not improving by sleep hygiene, then one can go for zolpidem. If a person is having depression, one can choose a sedative antidepressant. If one is having psychosis with sleep disturbance, one can go really with sedative antipsychotic. Similarly, if one is having sleep problems in dementia, one can choose quetiapine. So things like that. In the daytime, if we want to use anti-anxiety, then I would certainly tell them not to use alprazolam, which is a big no-no, because we have seen, I mean, you people must also have seen 200 to 400 milligrams of 0.5 milligram of alprazolam people are taking as it is. And they are coming to us that what to do now. So not to use alprazolam in any conditions. Of course, we use clonazepam, tell them to use it and restrict them to its this thing usage. It may be 0.5 milligram twice or at the most thrice a day, or 0.25 milligram twice or thrice a day at the most, not beyond it.
Right.
And the other thing is that do not give a free hand to the patient to use these molecules, these benzos, whenever you feel anxiety. So then they become, then they will not be, you will not be able to control it. They will not come for so many months, and when they will come back, they will be consuming 20, 40, 60, 80 tablets you are not aware of. So do not give any leash, any this thing to the patient. Always try to tell them that this is the molecule. Beyond it, if you are having anxiety, then try to adjust with the anxiety. And at the same time, you must tell them about the other non-pharmacological anti-anxiety things as well.
Right.
Right. So all these things are very, very important, which go hand in hand along with molecules. And we will have to tell them that 4 to 6 weeks after starting a benzo, it becomes ineffective.
Right.
It is only the rebound symptoms, the anxiety is there, but it is basically the rebound symptom. The medicine becomes ineffective in that dosage. So either you increase the dose, or you go for adding the non-pharmacological things or any other compound.
Right. Right. Thank you. Dr. Das. Yes.
Yes, this is for both Dr. Dalal and Dr. Prasad Rao. In that case, since we are talking about benzodiazepines and we are talking about from the perspective of GPs, but what about, can quetiapine replace clonazepam as an anxiolytic in case of anxiety disorder along with SSRIs? Like sometimes we prescribe SSRIs and also prescribe anxiolytic initially. Mostly say clonazepam, as Dr. Dalal has said. In that case, can we replace clonazepam in the psychiatric forum I'm asking about, and then prescribe lower doses of quetiapine? What is your opinion and take on this, Dr. Dalal and Dr. Prasad Rao both?
I personally have not used it. Neither, I mean, so much of recommendation, I have not heard about it.
Correct.
One can really use it, or one can really go for a double blind kind of a thing. But in general, when we start with SSRIs, generally they take over their effect in 2 to 3 weeks time, and we generally taper off these benzos in 4 weeks time.
Right.
So for a period of 4 weeks, I mean, giving a quetiapine kind of a thing, which is of course having certain side effects, which benzos do not have. And benzos, if we really use judiciously, and if we can taper off in due period of time, these are good and effective molecules. That is my take.
Right.
Yeah, I would also agree with what essentially what PK says. The only anxiety disorder which most of us use is quetiapine usage with OCD patients, especially the tougher OCD patients who had psycho. I don't think benzodiazepines can be replaced by low dose quetiapine because they are known to cause sedation, but not definitely a good control of anxiety. And our patients whom we treat have a significant anxiety, and the proof of the pudding is our patients, as soon as they take clonazepam 0.5 milligrams TAD, by tomorrow, doctor, you have saved my life. That kind of aha feeling won't come with the quetiapine.
Right, sir. I now move.
PTSD may have some role. Quetiapine may have some role in PTSD.
Okay, right, sir. I now move to Dr. Mahesh Gowda as we go into our last round of questions before we finish this panel. Dr. Mahesh, I mean, have you used a quetiapine clonazepam combination in your practice, since we are so much of talking about benzodiazepines?
Very rarely, because I think quetiapine has done more than what it actually needs to do as antipsychotic. It's definitely a good anxiolytic, and in a dose of 50 to 100, most of them don't need an additional benzo, is what I think. I very rarely use additional clonazepam along with quetiapine.
Right. Dr. Bhave, sir, question for you is that if you have you experience of, I mean, we've had, of course, Dr. Chowda in the earlier panel, but you know, your experience in particularly adolescents with psychosis. I mean, if you feel they do not tolerate risperidone well, would you switch to olanzapine or quetiapine?
No, I personally would prefer olanzapine because though not significant, it has a slight edge over quetiapine when it comes to efficacy in psychosis. So for me personally, between these two, olanzapine is a choice. In case there's a patient who is very agitated, very anxious, then perhaps quetiapine. But I think by and large, it's olanzapine.
Right. And sir, also, since you do visit hospitals and if you see patients in delirium, do you think quetiapine has any edge over the other antipsychotics?
Quetiapine I would use, especially in people who are, say, elderly. So people who are at a risk of development of more of metabolic side effects, or maybe elderly people at a risk for extrapyramidal side effect. So in those kind of cases, dementia with psychotic symptoms. So these are the cases in a, say, Lysian psychotic kind of environment where I would prefer quetiapine.
Right. Dr. O.P. Singh, sir, if you have a patient with diabetes, which is absolutely controlled and maintained well on oral drugs, and he develops schizophrenia, I mean, would you prefer risperidone versus olanzapine versus quetiapine? What would be your choice?
Obviously, risperidone will be preferred first.
Right. Any particular reason, sir, for that?
Of course, metabolic syndrome is lesser than these two, because even well-controlled diabetes can go into the diabetic coma,
right.
And that is all reported. Only thing is that if patient is maintained on quetiapine and he has diabetes is also maintained, then we like to continue with the medication, not changing it and adjusting the dose of anti-diabetic drugs.
Right.
De novo, if you ask me, one can go for aripiprazole first.
Yes.
Right. Yes, sir. Dr. Das, my one final one-line question to you. Quetiapine in schizophrenia, 100 to 200 mg versus 400 to 600 mg. Your choice.
400 to 600.
Okay. Dr. Prasad Rao, sir, quetiapine in acute mania, 600 to 800 versus 1000 to 1200. Your choice.
An average is 600, 800 always. But at least 20% of them would need to go up to 1200. I have that 25% proportion of my manic patients who received, in fact, the largest dose I gave is around 1600 milligrams for a difficult patient of mania. But my 60% choice would be up to 800.
Right. Mahesh,
this is one-liner question, I suppose.
Yes. Mahesh, quetiapine lurasidone combination, is there something in there?
I think definitely you can use a combination like that, because there seems to be some additive effect when you're trying to combine weight reduction molecule like aripiprazole or lurasidone, and it does not add up to the sedation also. So you want a little more efficacy of the molecule. You cannot reach higher because of cost or tolerability issues. You can add a drug like lurasidone or aripiprazole. I think I still feel there's a scope for it.
Right. My last question for this panel is to Dr. Bhave. Sir, any experience with the quetiapine glonanserine combination? I know I'm playing a very bad devil's advocate here, but I'm just asking. Yeah.
If you're asking about experience, no.
No, right, fine. Well, that brings us to the end of this panel. We are very happy to have with us, of course, Dr. P.K. Dalal, sir, Dr. Prasad Rao, sir, Professor Dr. O.P. Singh, Dr. Bhave, Dr. Jayanta Das, and Dr. Mahesh Gowda, and Dr. Suresh Kumar, who's still with us from the evening. So it's an absolute pleasure to have you all here for this panel. It's been an interesting panel. I think today was a festival day, so our attendance has been in the range of 150 to 160. We've not had 500 and 600 like we've had in our other webinars, because I think two halves of the country are probably busy with festivities. So I think that's why we have had little less attendance. But nevertheless, we've done very well. And it's been an amazing evening to, interview all of you all and take your opinions on quetiapine. And I'm sure the INTAS people would bring this recording to a lot of doctors ahead from here. And I would like to have Michael say the final words. Michael, please.
Thank you very much, sir, Dr. Avinash, sir, Dr. P.K. Dalal, and Dr. Prasad Rao, and the galaxy of eminent panelists, including Dr. Jayanta Das, Dr. O.P. Singh, Dr. Gautam Shah, and all of you for contributing in this wonderful clinical experiences. What is very important is the clinical experience is something which the general physician is what is most important to them. And I think, sir, you have shed a lot of light in the entire spectrum of its usage. And I'm very happy, sir, that this is a very good initiative that has helped the understanding for the entire medical fraternity. Thank you very much, sir. Thank you to all of you.
And congratulations, Avinash.
I would like to
Congratulations, Avinash. You have done an excellent job.
Thank you.
And in a lighter vein, I have one
special thanks to Avinash.
Can I express it?
Yes,
Michael.
Prasad Rao, in a
I
lighter
would
vein, I
like
have one
to
complaint.
congratulate Avinash. I would like to congratulate Avinash for the really tough questions he asks for the panel. He chooses the panel members sufficiently good, so that the tough questions normally go to the gray hairs or bald head people.
I have one complaint against G. Prasad Rao in a lighter vein. Can I make it, Prasad Rao?
Please.
Yeah, Jayanta, always.
You are munching something alone, and I can see that.
Okay.
You could have virtually shared with us, right, OP?
Yeah. No, I will be going to Hyderabad very frequently and sharing with him.
Jayanta, I broke my fast just now.
COVID goes, so
I broke my
will be
fast.
traveling
I
to
have to
Hyderabad
break
very
before some
frequently
time.
now.
So that's why I have to
Anyway,
eat something.
congratulations, Avinash, and thank you, Dalal sir, Dr. Bhave, Dr. Suresh Kumar, OP.
Thank you, sir. It is a pleasure with everyone.
Thank you. Have a great weekend. Thank you.
Good night. Good night.
Have a very nice weekend. Okay, bye-bye. Bye.
Suresh Kumar and Dr. P. N. Suresh Kumar. Thank you. Thank you for us being a speaker. Thank you, Dr. Suresh Kumar.
Bye.
Good day, sir. Good night, sir.
Thank you, sir. Thank you so much.
Prashant.